Hi everyone, Dr. Mike here. Now let's take a look at the different types of blood vessels we have in our body. So what I've drawn up down the bottom is we have the larger blood vessels that are coming from the heart that we term arteries, okay? So remember, here's the left-hand side of the heart. The important thing about the left-hand side of the heart is that it's delivering blood to the body. So this is where blood gets ejected from the heart through the aorta, and then you can see it gets distributed to all these various parts, tissues. This includes the coronary arteries, the brain, the gut, the renal system, the muscles and the skin, plus other areas of the body. And that means that the large vessels that exit the left-hand side of the heart are under high amounts of pressure because that left ventricle contracts really, really hard. In actual fact, the strongest pressure coming out of that left ventricle is 120 millimeters of mercury. That's quite a strong contraction. In actual fact, if we were to measure that not in mercury, but measure that in water, it would be around about 3 meters of water. That means if that left ventricle contracted under its highest pressure, it could squirt water around about 3 meters out. All right, now this is an artery right here, and arteries, what you need to know about arteries, are comprised of elastic tissue. Really important point, elastic tissue. Why? Because when it's under high pressure, it needs to stretch. And the important part about stretching is that it recoils, snaps back into place. So that means that arteries are filled with elastic tissue and they are compliant. Really important point. As you get older, sometimes they can harden, stiffen, and they become less compliant, which means they don't stretch very well under high pressures, which means they're more likely to be damaged under high pressures. Hence why people as they get older can have stiffened arteries, but also increased likelihood of damage to those arteries, forming atherosclerosis, and that can lead to a plaque being built up, and that plaque can detach, a thrombus can form, and now that's a clot that can potentially travel to the brain, stroke, the heart, heart attack, okay? So arteries, compliant elastic tissue. As we move from arteries, they branch off into these multiple smaller blood vessels called arterioles. Now these arterioles, as you can see here, they lead into capillary beds. But an important point about arterioles are they have heaps amount of, is it elastic tissue? No, it's smooth muscle. They have huge amounts of smooth muscle surrounding them. Now, why is this important? It's important because you can tell muscle to contract. And if you've got muscle surrounding a tube and you tell that muscle to contract, it narrows the hollow inside of that tube. Now think about it. Blood's moving through here. If it wants to go, let's say, to the gut, but the muscles constrict and limit the amount of blood going in, it means the blood backs up, backs up, backs up. If you do that to multiple areas of the body, you're going to increase the amount of blood in the systemic circulation and increase the pressure. Just like having a hose and putting your thumb on the end of the hose, the pressure increases, right? And so what that does is it increases the pressure. So arterioles have lots of smooth muscle, and this makes them resistance vessels. I said arteries have elastic tissue, they're compliant. You've got arterioles have smooth muscle, and they are resistance vessels. They can play around with blood pressure. Now what we have right in the middle here are the capillary beds. Now this is the site of exchange. We're exchanging gases, we're exchanging nutrients, we're exchanging metabolic waste products. And you can see that capillary beds are porous, and that means they have holes in them. And you can have different types of capillary beds and different sized pores, okay? So for example, you can have these sinusoidal capillary beds, and they are located in areas where you need mass exodus of fluids, proteins, cells. This can happen in the bone marrow, for example. They're sinusoidal, but at most of the tissues, they're just porous holes that are so small that not even proteins or cells can leave them. Simply the fluids, the ions, the gases, and the waste products can go back and forth. So that means that capillaries are porous and they're the site of exchange. Then we move on the other side of the capillary bed where we have venules and then veins, okay? Venules gather all that blood that's just been exchanged at the capillary beds, and they then put them into a vein or multiple veins, larger vessels that go back to the heart. And we know from there it goes to the lungs to get that oxygen. Now, venules and veins have a thinner wall than you'd find with the arteries and arterioles, but what you'll find is they can be larger in diameter, and what you'll find is because of their thin walls and their larger diameter, it means they can hold most of the blood. Most of the blood in the circulation is actually sitting in the venous system, which makes them capacitance vessels, okay? So what do we have now? So just to summarize, we have arteries, elastic tissue, compliant. Arterioles, smooth muscle, resistance. Capillaries, porous, exchange. Venules and veins, thin-walled, wider diameter, capacitance vessels holds most of the bloods. So that's a quick run through of the blood vessels of the body. In this video, we're going to have a look at capillary exchange. So capillary exchange happens at capillary beds, and this is the exchange of bulk fluids out of the capillaries. And once this fluid has exchanged out of the capillary, it's able to, via the process of diffusion, hand over the oxygen, hand over some of the nutrients that's required for the tissues, and also the tissues need to hand over to that fluid carbon dioxide and also some metabolic waste products like urea, for example. So basically we have, and you need to remember this, when the heart contracts, when that left ventricle contracts, it's pushing out oxygenated blood, which has nutrients in it, out of the left ventricle into the aorta. Now remember where this blood goes. Once it goes out via the aorta branches into all of its aortic branches, and these continue to branch like a tree. Now as these arteries, because it's leaving the heart, as they branch, they get smaller in diameter, but they become more numerous, okay? And all of these branches end up feeding all the tissues of the body. Now, every minute, that heart's going to contract and relax, contract and relax, contract and relax. Every minute, this is going to happen around about 72 times, okay? So you have around about 72 beats of your heart per minute. Every contraction pushes out approximately about 70 mils of blood. So 70 mils pushing out is called your stroke volume. Every contraction pushes out 70 mils times 72 beats in a minute, means that in a time span of 1 minute, your heart will push through 5 liters of blood, okay? So this is on both sides of your heart. So remember, the left-hand side of your heart deals with oxygenated blood and delivers it to the whole body. Every minute, the left-hand side of your heart will deliver 5 liters of blood to the tissues of your body. The right-hand side of your heart deals with deoxygenated blood, and therefore this blood needs to get to the lungs. And again, every minute, this side of your heart will push out 5 liters of blood. So if we just have a look at what I've drawn here on this side of the whiteboard, you'll see we've got the heart. If we have a look at the left-hand side of the heart, when it contracts, pushes blood out of the aorta branches into all of its aortic branches and then further branches into smaller arterioles. And these arterioles will then lead into capillary beds. And these capillary beds could be capillary beds of the coronary arteries, cerebrovascular capillary beds of the gastrointestinal tract, of the renal system, of the musculoskeletal system, and also the skin. Okay, these are just potential places that this blood could go through. Now remember, as it gets to the capillary bed is the site of exchange, and that's exchanging gases, oxygen and carbon dioxide, and also nutrients and waste products. Then on the other side of these capillary beds, we have veins. Okay, veins will always go back to the heart, and you can see they will come together, and these veins will get back to the right-hand side of the heart via the vena cava, whether that's the superior or the inferior vena cava. Now it's at the right-hand side of the heart. It will contract and push that deoxygenated blood where? To the lungs to get oxygenated. And again, this blood's coming through to capillary beds of the lungs. If we look at this portion, so the blood that's going to the body, every minute 5 liters. If we look at this portion, going to the lungs, every minute 5 liters. But here, this blood is partitioned to various tissues. Now, why am I bringing this up when we're talking about capillary exchange? Because when the blood's pushed out the left-hand side of the heart, it's under a particular amount of pressure. Okay, and in one of the previous videos I've spoken about blood pressure, and I spoke to you about the fact that a normal blood pressure is 120/80. 120 is the systolic value, so 120 is telling you that when the heart contracts under systole, this is the pressure that the blood exerts on the walls of your arteries, 120 millimeters of mercury. The bottom value, 80, is the diastolic value, and this is the amount of pressure within those arteries when the heart is relaxing. Okay? Now, Saying 120/80 is important clinically, but to know what the mean arterial pressure is, I told you that you need to take the diastolic value and add 1/3 of the pulse pressure. Now, if you're unsure what that means, go back to the previous video looking at blood pressure and that'll explain it all. But mean arterial pressure is 93 millimeters of mercury. That's just saying that going through the arteries of the body, the mean pressure that the blood is exerting on the walls is 93 millimeters of mercury. And as this 93 millimeters of mercury starts to move through these various branches, the pressure drops. And by the time the blood reaches the capillary beds, it's no longer 93 millimeters of mercury. By the time the blood reaches the capillary beds, the pressure of the blood inside the capillary beds is 30 millimeters of mercury, between 30 to 35, okay? Now, what does that mean? It means that blood's going to move through these small arterioles until it gets into a capillary bed. And you know capillaries are porous. That means they have holes in them. And you can see these little holes through this capillary bed, okay? Now, this blood's getting through, and by the time it reaches what we call, you can see one side of the capillary bed I've drawn red, the other side I've drawn in blue, because one side is the arterial end, and the other side is the venous end. Because remember, arterial blood is oxygenated, venous blood is deoxygenated, which means that here we have that stuff coming out, and here it's no longer oxygenated. So blood's being pushed out of here, exchanging gases, so pushing out oxygen, taking in carbon dioxide, and here we now have deoxygenated blood, and this blood is ultimately leaving the tissue and going back to the heart and then to the lungs. So, as this blood's coming through, as it gets into the arterial end of the capillary, there is a blood pressure that's pushing out. And this blood pressure is, like I said, 30 millimeters of mercury. Now, remember, pressure that we measure in blood vessels is simply as the blood moves through the vessel, blood is pushing on the walls of those arteries. There's no holes in the walls of arteries. They're not porous, so blood cannot leak out, okay? As those arteries branch out even further and get smaller in diameter, they turn into arterioles. And again, arterioles don't have holes, they don't have pores, so blood cannot be pushed out. But it's when those arterioles branch off into these smaller capillaries, that's when they have these holes and these pores, and therefore as the blood comes through and pushes on the walls, it can leak out. And so once we get to the capillaries, we now have 30 millimeters of mercury pressure pushing on the walls, and that means that this fluid, this blood fluid, is being pushed out of the capillaries, okay? At 30 millimeters of mercury pressure. Now, the important point is this. You can see that there's little holes in the walls of the capillaries. These holes are of a particular size, okay? Now, what is in blood? You need to remember what's inside of blood. It's not just a fluid. Inside blood, we have red blood cells, we have platelets, we have white blood cells, we also have what? Proteins. Okay? So all these substances of the blood is coming through. Now, these holes are too small to let white blood cells, red blood cells, platelets, and proteins out. Okay? They're too small. So, you remember diffusion. Remember that in diffusion, if you have a concentration difference of a substance on one side of a membrane compared to the other side of a membrane, that this concentration difference will want to balance itself out. Okay? So if I can draw it up here very quickly, if I would have a container and I was to put a membrane in between, a semi-permeable membrane, and I was to fill both sides up with water, and on one side of the membrane I was to put some substances, some particles, and on the other side I don't put any particles. Well, under diffusion, these particles on this side, so side A compared to side B, the particles on side A would want to diffuse from its high area of concentration towards its low area of concentration. Okay? But there's a membrane here, and this membrane will not let these particles through. So it cannot diffuse across from A to B. But there's osmosis. And osmosis is the movement of water through a semi-permeable membrane from an area of high water concentration to an area of low water concentration. What that means is basically this. These particles on side A exert a pull. Okay? They exert a pull of that water from side B to side A. So that means in order to balance out the concentration on both sides, these particles pull water towards them. Okay? What happens to the water volume on this side? It starts to rise up. Okay? So think about that in regards to the blood. We have the blood moving through, and it's exerting pressure on these walls at 30 millimeters of mercury. There's holes here so the fluid can leak out at 30 millimeters of mercury. But we have substances inside that cannot move out. These substances want to diffuse out of the vessel, but they cannot. There is a semi-permeable membrane in between. So what that means is these substances exert a pull back in. They exert a pull because there's a high concentration of particles here and a low concentration of particles here. So they actually exert a pull. Now, of all these particles, so I said red blood cells, platelets, white blood cells, proteins, which of these exert the strongest pull? The answer is the proteins. Now, the next thing is, which proteins? You should know what the most abundant protein is within the blood. It's called albumin. And this albumin protein is very important in eliciting a pull of the fluid back in. Okay? Now the strength of this pull, is 20 millimeters of mercury. Now, I want you to have a look at this. We have a push out of 30 millimeters of mercury and a pull in at 20 millimeters of mercury. When you have two pressures opposing each other, the stronger pressure will always win. What if you have two people pushing against each other and you say to one of them, push harder than the other person? That person's going to win. Okay? They're exerting more force. So, if you have a look at these two, which one's exerting more force? The 30 millimeters of mercury pushing out. That overpowers the 20 millimeters of mercury by, what's the difference? 10 millimeters of mercury. Okay? What that means is, at the arterial end of a capillary, stuff gets pushed out. Okay? There's a pull back in, but overall, stuff gets pushed out. Now, of the stuff that gets pushed out, this is fluid. This is a bulk push of blood fluid coming out. And in this fluid, it has gases because they're small enough to get through in the fluid. And it has substances like glucose. They're small enough to get through these gaps as well. And then this fluid can exchange with the tissues. Now, as we move across from the arterial end, because remember, blood's moving through like this. It's coming through, pushing out. As we move from the arterial end to the venous end, I want you to think about what happens to this pressure. If you had a hose and you were to connect that hose to a tap, and you turn that tap on at a particular pressure. So you turn it on, let's say you turned it on halfway. And you had a look at the hose, let's say the hose is 10 meters in length. You look at the other end of the hose and water's squirting out that end at a particular pressure. Okay. Let's say you were to now put holes in that hose. So let's say every meter for the 10 meter hose, you put a hole. Hole, hole, hole. And you have it turned on at halfway, and you have a look at what's happening. At those holes, you see water squirting out, right? Now let's say you have a look at the hole that's closest to the tap. The water's going to be squirting out of that hole at a particular pressure, at a particular height. As we move down, what do you think? So just think about what's going to happen to the pressure of that water pushing out of those holes. Is the pressure going to increase or decrease? Is the water going to push out at a higher distance or less? Well, think about it. Hose is turned on. Water's pushing out at a particular height closest to, but because that water's leaving, the pressure drops distal to that. And then the next one squirts out, but it's a little less. And then the next one drops, a little less. So the pressure decreases as you move down the hose because of these holes are reducing the pressure as we're moving through. That's what happens in capillaries. So as we move from the arterial end, stuff's getting pushed out, so the pressure in here drops. And that means at the venous end, the pressure drops enough that it ends up being a push out of 15 millimeters of mercury. Now, these substances, such as, and I'm just going to draw the albumin, is continually moving through. So it's still on this side of the venous end of the capillary. Okay? So these substances are moving through, so these proteins are still exerting a pull of the fluid back in. And this pull is still around about 20 millimeters of mercury. So have a look now. If you were to measure the pressures against each other, which one now wins? Well, 15 out, 20 in, the pull in now wins. The difference, 5 millimeters of mercury. So what that means is, at the arterial end, we have a bulk flow or a net flow of fluid being pushed out. And then when we get to the venous end, we have a net flow of fluid being pulled back in. And the reason why this is important is because the fluid that's on this end is handing over oxygen and substances like glucose, and then it's continuing past. And then on this end, the tissue is handing it carbon dioxide and waste. And why is that perfect? Because this is where the fluid gets pulled back in and can get taken back to the heart. Perfect. Perfect, perfect, perfect. Now, the push out and the pull in have names which you need to know. Okay? So, the push out, remember I've drawn it in red. So the push out is called the hydrostatic pressure. And basically it's blood pressure, right? Because it's the pressure of the blood being pushed in the walls of the arterial end of the capillary. Okay, the pull in, which I drew in blue, so I'm just going to draw the blue arrow here. The pull in is called colloid osmotic pressure. And I told you it's the pull of the proteins in the blood pulling that fluid back in. Now, let's just think clinically for 1 second. What if we were to increase the size of these gaps in the capillaries? Let's say they're now big enough for proteins to move out. So that means that as the blood comes through, 30 millimeters of mercury pressure pushing out, not just fluid comes out, but also the proteins come out as well. If the proteins leave the capillaries, is there any pull back in? No. So that means we have all this bulk flow out, including proteins, and there's no proteins to move to the venous end, so there's no pull back in, which means fluid just continues to accumulate outside the capillaries in an area called the interstitium, meaning between the tissues. This is edema. So when you see a patient who has fluid build up at the bottom of their legs or at their periphery, this is edema. And it can be due to, one of the reasons, a widened gap between the endothelial cells of your capillaries. Think about inflammation. Inflammation is just injury or damage occurring to vascularized tissue. Everyone's had some form of inflammatory response. Let's say you've cut your hand. What happens? You've got the 4 cardinal signs of inflammation. You've got the redness, you've got the swelling, you've got the heat, and you've got the pain. Okay, these have been known for thousands of years. But What's one of those that we need to remember? Swelling. So you cut yourself, you always notice swelling at the site. Why? Because when you damage cells of your skin, these cells explode their guts and inside there's histamine. And histamine is a chemical that creates larger gaps in your capillaries. Why? Why would we want this? Because if I were to cut myself, whatever cut me, let's say it was a nail, what if there was bacteria on that nail? I now have bacteria in my interstitium, okay? How am I supposed to attack it and kill it if all my white blood cells are in my capillaries? Well, histamine opens up the gates, and my white blood cells can come out and attack the bacteria, kill it off. But what that also means is fluid comes out. But this is good as well because the fluid sort of washes it away and dilutes it. Okay? Now, you may think that of all the fluid, under normal situations, of all the fluid that gets pushed out on the arterial side, that it all gets pulled back in. That's not the case. There is a small percentage of this fluid that once it gets pushed out, it cannot get pulled back in. Now, this is enough, even though it's a fraction of the fluid, it's enough that at the end of the day, if we could not find a way to pull that fluid back in, if we could not pull that fluid back in, our blood pressure would drop enough that we'll die at the end of one day. So it means that of the fluid that can't get pulled back in, we do have a mechanism. We need to get that fluid back. How do we get it back? The lymphatic system. So we have lymphatic vessels as well around our tissues. And the lymphatic vessels help bring back that lost fluid from capillary exchange and drops it back into our venous supply. So I hope that this made sense looking at capillary exchange. Hi everyone, Dr. Mike here. In this video we're talking about blood pressure, but more specifically we're talking about one part of the blood pressure equation which is really important, something called systemic vascular resistance, also known as total peripheral resistance. I know it sounds like a mouthful and doesn't seem to make sense from the beginning, but let's have a quick look. When we look at blood pressure, all blood pressure is the amount of force exerted on the walls of the blood vessel when the blood is moving through. So for example, this is the left-hand side of the heart which delivers blood to the whole body. As you can see, the heart, the brain, the GIT, the renal, the muscle, the skin, and multiple other aspects. Now in order for the blood to get from this left ventricle or chamber, it needs to travel through these blood vessels to get there. And it does so when that left ventricle contracts. Now when it contracts, it squeezes blood, which obviously pushes blood, and as that blood pushes through, it's going to put pressure on the walls of these vessels, and that simply is blood pressure. Now we know here from the left ventricle to the aorta that the blood pressure is going to be around about 120 millimeters of mercury under its strongest contraction. Okay, that's pressure. Now this blood pressure we can gather from an equation which involves cardiac output, which is the amount of blood we eject every minute, and multiply that by what we're talking about today, the systemic vascular resistance. Now, let's have a look what systemic vascular resistance actually is. When this blood moves through from the aorta, the large elastic vessels, and then goes to all the areas where it branches off to different tissues of the body, these smaller arteries we term arterioles. These are the arterioles here. And something I've told you about in the past is that arterioles have huge amounts of smooth muscle in the inside layer of their walls. So that means all of these arterioles have smooth muscle around them. All right, now what does that mean? Well, it means that muscle can contract. And if you've got muscle lining a tube and it contracts, it narrows the hollow inside of that tube, which means less blood can move through. Now, an interesting thing is when we talk about pipes and fluid movement, especially in the bloodstream, if I have a pipe of a particular length and then I halve the size of that pipe in regards to halving the diameter of that pipe, you would think that we have now halved the amount of blood that can go through. But in actual fact, it is to the power of 4. So that means 1 over 2 times 2 times 2 times 2. That actually means 1/16. That means instead of halving the amount of blood when you halve the diameter of the vessel, you decrease the amount to 1/16. Only 1/16 of the amount of blood gets through. So that means when I constrict any of these particular arterioles, I significantly alter how much blood goes past, going to the various tissues of the body to feed it, right? Now let's think of an actual scenario that happens in our body. You are walking in the park late at night, you hear a rustle in the bush, and then all of a sudden a big dog jumps out and starts barking at you. What happens? You get scared, you activate that fight or flight system that we term the sympathetic nervous system. Now, when you activate the sympathetic nervous system and you get scared, you can feel your heart beat harder, stronger, faster, but also if you looked into a mirror, you'd look white. Now, why do you look white when you get scared? Because your sympathetic nervous system, which is the home of adrenaline, gets released into your body, and this adrenaline goes to the arterioles of the skin, which has lots of muscle, and it tells it to constrict. The blood vessels feeding your skin constrict. Now, 5% of all the blood that exits your left ventricle, 5% goes to the skin, which means when they constrict, that blood doesn't go to your skin, so you turn pale and backs up into the system. Another thing that happens is your GIT, your gastrointestinal tract. When you're scared, you don't need to use that, so the muscles there constrict as well in the arterioles, and 25% of your cardiac output or blood that comes out of your left ventricle every minute goes to your GIT. So now 25 plus 5%, 30% of your blood volume gets shunted back into this systemic system. Now again, when you put your thumb on the end of a hose, this is what you're effectively doing here. The pressure backs up and increases. So backs up, increases. And what have we now effectively done? Simply by changing the diameter of these tubes, we've increased blood pressure. So systemic vascular resistance, also known as total peripheral resistance, if you decrease the diameter of it, you're going to increase the resistance. You increase the resistance, you increase blood pressure. Now, this is diameter, but you can also change systemic vascular resistance by changing the length of the tube, the length of the blood vessel, okay? Now think about this. You have a 10-meter long garden hose at home and you turn it on. You see at the other end, water's squirting out at a particular pressure. Now, if you were to keep that tap turned on at the same pressure, yet you lengthen that tube to 1 kilometer, what do you think the pressure would be on the other end of that tube? Would it be coming out at the same pressure as the 10-meter tube? No, it wouldn't. The pressure would be decreased, because the longer a blood vessel is, the more the blood gets stopped by it as it moves through, right? So there's more resistance. Therefore, what you get is a problem. That means, in order, think about this. If I had, instead of a 10-kilometer long blood vessel, I had a 1 million kilometer long blood vessel, it means that at the other end of that vessel, the pressure is going to be lower with my heart just pumping normally. So my heart would need to respond by pumping harder just to get the same pressure on the other end, just to get these tissues fed. When's a clinical example that this is going to happen in? Individuals who are obese. The larger your body mass, the longer your blood vessels. For every kilogram of fat that you put on your body, you need to generate at least 1,000 kilometers of blood vessels, which means the heart, in response, needs to pump harder just to get the same amount of pressure getting to your tissues. That means there's more strain on your heart over time. That means increased likelihood of cardiovascular disease. All right, so that's length, but you can't change length in the short term. You can change diameter in the short term through the sympathetic nervous system. Can't change length in the short term. That's over time, increasing body size. And viscosity is the last way you can alter systemic vascular resistance. Viscosity is how many things are in your blood. How thick is your blood? Now, how do you change this? Well, you can change this with the number of red blood cells, okay? So some people can have polycythemia, which is too many red blood cells. That makes your blood thicker, which means if the blood's thicker, it's harder to move through, and it increases systemic vascular resistance. Or you can have anemia and it's thinner, and it's going to affect systemic vascular resistance. Or you could blood dope with erythropoietin, EPO, as some cyclists have done in the past, and that will also make your blood more viscous and again increase systemic vascular resistance. All right, so when it comes to blood pressure, your blood vessels themselves, diameter, length, viscosity, have a very important role in altering that blood pressure. Now, another way that you can alter the diameter of your blood vessels, so I said short-term constriction. In the long term, you can see your kidneys require 20% of your cardiac output. Really important. If that drops for any particular reason, your kidneys actually respond by releasing a hormone called renin, which then stimulates the release of another hormone called angiotensin II, and that tells the skin to constrict or at least tells the blood vessels to the skin to constrict, and it backs the blood up, increasing pressure again and saying, hey, skin doesn't need it, I need it, and it backs up. That's the renin-angiotensin-aldosterone system, and I'll do an entire video just on that. In this video, we're going to take a quick look at blood pressure. Now, blood pressure is the pressure or the force that the blood in your vessels exerts on the walls of that vessel. Okay. Now, how do we generate this sort of pressure? Well, today we're going to have a look just at the left-hand side of the heart, because the left-hand side of the heart deals with oxygenated blood that it needs to deliver to the whole body. You know that when that left ventricle contracts, pushes blood up into the aorta, and the aorta branches numerous times and ultimately leads to capillary beds at the tissues for the tissue to get fed. Now, without the right amount of pressure behind the blood pushing it through, the blood will not get to the tissues and perfuse at the sites in which it needs to, meaning it won't be able to feed those tissues. So blood pressure is required for perfusion in order for the blood to feed the tissues at the appropriate sites. And you know that that left ventricle, when it contracts, needs to send the blood to the top of your head to the tip of your toes. So there needs to be a relatively high amount of pressure being generated from that left side of the heart. The reason why we're not talking about the right-hand side of the heart today is because when that contracts, it's just sending the blood to the lungs. Now, yes, that's important, but the lungs are not very far away from the heart, are they? So when the right-hand side of the heart contracts, it does not generate a huge amount of pressure in order to get the blood to the lungs. We want to talk about what we call the systemic blood pressure. And the systemic blood pressure is generated by the left-hand side of the heart, specifically the left ventricle. So what I've drawn up here is the left-hand side of the heart. So I've got the left atrium and I've got the left ventricle. And you know that the left ventricle leads to the aorta, and that the aorta is going to branch numerous times, and that's going to branch again into arterioles. Okay? So I want you to remember that this is left-hand side of the heart, left atrium, left ventricle, aorta, and all these branches, and these are arterioles, ultimately go into capillary beds. Okay? Now, when the blood from the pulmonary vein fills that left ventricle, it's now oxygenated, because pulmonary vein means from lungs. So this is oxygenated blood coming from the lungs, going into the left atrium, contracts, pushes blood through the bicuspid or mitral valve into the left ventricle. And you know that the walls, the muscular walls of the left ventricle are extremely muscular. Okay? So when this muscle contracts, it squeezes and pushes blood up through the aortic semilunar valve into the aorta. Now, important point. When the left ventricle contracts, this is known as systole. Okay? So contraction is referring to systole. When this left ventricle relaxes, that's called diastole. So contraction, systole, relaxation, diastole. Let's write that down. Systole is contraction, diastole, relaxation. All right, so you must keep that in mind. Now, blood's filled that left ventricle. Now that left ventricle contracts, so that's systole. And what happens when that left ventricle contracts? As that left ventricle contracts, the blood gets pushed up through the pulmonary semilunar valve and goes into the aorta. Now, when it contracts, it produces a certain amount of pressure. And I told you that pressure is the force of the blood on the walls of the vessels. This pressure that's generated in this left ventricle under systole, under contraction, is 120 millimeters of mercury. Okay? Now, this pressure gets transmitted into the aorta. So the 120 millimeters of mercury gets transmitted into the aorta, and because the aorta is very stretchy, the aorta starts to bulge out. So what you can see is this. Left ventricle contracts, systole. creates a pressure inside that left ventricle of 120 millimeters of mercury. That blood, with a pressure behind it of 120 millimeters of mercury, is pushed into the very distensible, very stretchy aorta, and the 120 millimeters of mercury stretches the aorta out. Okay? That is what we call the systolic blood pressure. And therefore, it's 120 millimeters of mercury. Okay? Now, when that left ventricle relaxes, the pressure inside this left ventricle drops. And that means these valves close because the blood that's here in the aorta wants to come back down. There's no more pressure behind it. So the blood that's pulled here wants to come back down, but luckily the aortic semilunar valves close. Now, the other thing is this, because that aorta was stretched out under systole, just like a rubber band would be, when this ventricle relaxes, this rubber band recoils and comes back in. Now, as this rubber band recoils and comes back in, what do you think happens to the blood that's pulled here? It gets pushed forward. Okay? Now, because even though the left ventricle is relaxed, it means that because of the stretchability of the aorta, that the blood could continually be pushed through. So basically, if contraction, blood comes out, distends, that pressure on the wall is 120 millimeters of mercury. Then, when the ventricle relaxes, the aorta comes back in, it recoils back in, and continues to propagate blood through. This pressure that's propagated from the recoil of the aorta is the diastolic pressure. And so the diastolic pressure is about 80 millimeters of mercury. Okay? The diastolic pressure is about 80 millimeters of mercury. Now, hopefully that makes... So that's why when you measure your blood pressure, so remember, the aorta branches off. One of the branches is the brachiocephalic branch. Okay? And the brachiocephalic branch is going to come down into the subclavian, and the subclavian is going to come down into the brachial, and you're going to have your brachial artery. And what do? You measure blood pressure from the brachial artery. Whatever pressure is in that brachial artery is reflecting the pressure of the aorta and what that aorta has generated. Okay? And when you do this, I want you to think about when you do manual blood pressure readings, you have that cuff and you wrap the cuff around the patient's arm and you pump that cuff up. You put pressure in the cuff because if you have your brachial artery with blood moving through, you know that blood's moving through in a fashion like this. Contract, up, blood's being pushed through, aorta distends, left ventricle relaxes, recoils, continues to push blood through. That's why blood doesn't squirt through your arteries like this. Blood is consistent. Push through under systole, continues to push through under diastole. So push through when it contracts, continues to get pushed through under relaxation. Okay? 120 when it's contracted, 80 millimeters of mercury when it's relaxed. Now, if we have a look at this blood vessel, you're going to have pressure being placed upon the walls of this blood vessel, the brachial artery, and you're going to wrap a cuff around and pump it up. Now, when you pump that cuff up, what's it feel like? It feels like it's getting tighter on your arm. And that means that the cuff starts to, if we had this cuff wrapped around the vessel, as you pump up the pressure, it starts to push on the artery. Now remember, what's the outward force on this artery? Well, under systole, it's 120 millimeters of mercury. So, under systole, you have 120 millimeters of mercury pushing out on this vessel. So what do we need to do in order to close this vessel up? If we wanted to close this vessel and block it all the way up, we need to put equal to more pressure in the opposite direction. That makes sense. 120 millimeters of mercury pushing out, we need to put 121 millimeters of mercury pushing in. And that's what we do. We pump the cuff up to about 160, 170 millimeters of mercury just to make sure. And that means that it's fully occluded. The pressure going in is beating the pressure coming out. And what do? You take the stethoscope and you put it on the brachial artery and you listen. And then what you hear is nothing when it's fully occluded, fully blocked, okay? But then what do? You slowly release the pressure of the cuff, and the cuff starts to come out and out and out and out. Now, as soon as the cuff has come out enough that a little bit of blood can squirt through, what does that mean? If the cuff has come out enough that a little bit of blood can squirt through, that means that the pressure inside the vessel is just overcoming the pressure of the cuff, which means under contraction, under systole, there's a certain amount of pressure coming through and it's overcoming the cuff. Now, that's your systolic reading. So when you have your stethoscope on listening as you're releasing the pressure, you'll hear a ch sound. And that is going to be your systolic value. You look at the reading, the reader on the sphygmomanometer. You have a look at the reading and that's giving you your systolic value. Then you continue to release the pressure and you'll keep hearing these sounds until the sounds stop. When the sounds stop, it means the vessel is fully open and there's a constant flow of blood through. As soon as you stop hearing that sound, that's your diastolic value. It's meaning that the smallest amount of pressure being generated in this vessel is even able to get past. Okay? That's measuring your manual blood pressure. Now, last thing I want to talk about is when we look at blood pressure, you need to think of the calculations that go towards it. Now, I told you that 120/80 is the normal blood pressure, whatever that may mean. But I want to talk about what things can alter blood pressure. Okay? Now, I'm going to do another video on the things that can alter blood pressure, but I just want to introduce in the last 1 minute of this video this very important little equation, which is blood pressure is equal to cardiac output times systemic vascular resistance. What does this mean? It means the blood pressure, the pressure that the blood is exerting on the walls of your artery, is equivalent to cardiac output. This is the amount of blood being pushed out of your left ventricle over time. How much blood is being pushed out of your left ventricle over time? Blood quantity, basically, volume. Systemic vascular resistance. Well, this is the systemic blood supply here, and it's referring to vascular, meaning blood vessel resistance. So how much resistance are these blood vessels putting on the blood behind it? Now this is important because your arterioles have smooth muscle wrapped around them. And this smooth muscle can either constrict or dilate. If this smooth muscle constricts, what do you think happens? The blood pulls backwards and the blood pressure increases. If they dilate, more blood can be pushed through and the blood pressure on the walls back here are less. Okay? So the amount of blood coming out of the heart multiplied by the amount of resistance being experienced distal to the arteries can regulate blood pressure. In the next video, I'm going to talk about this in detail because all the antihypertensive drugs that we give our patients will either alter cardiac output or it will alter systemic vascular resistance. Hope that made sense. Hi everyone, Dr. Mike here, and in this video we're going to talk about blood pressure and how some of the common blood pressure medications actually work. So remember that a normal blood pressure is around about 120/80. Now all blood pressure is the force of the blood on the walls of the vessels inside. Now if somebody has hypertension, it means that they've had constant blood pressure measurements and they've been higher than this 120/80. Now the problem with this is that if you have high blood pressure over time, it can damage the walls of the blood vessels. This makes sense. If you increase the pressure within a hose, increases the likelihood of the walls of that hose getting damaged. So we want to decrease blood pressure if somebody is hypertensive. So that means chronically increased blood pressure. So how does this work? Well, let's have a look at the equation for blood pressure. Blood pressure equals cardiac output times something called systemic vascular resistance. All right, let's have a look. What is cardiac output? This is simply the amount of blood your heart pumps out per minute. So how could we calculate that? It's simple. You take something called the stroke volume. This is the amount of blood pumped out per per contraction, stroke volume, and you multiply it by how many times your heart contracts in a minute. So stroke volume, a single contraction, how many times per minute? Stroke volume is usually about 70 milliliters. Heart rate's around about 75 beats per minute. This ends up being between 4 to 5 liters of blood every single minute. This is cardiac output. Now what you do is you multiply this by something called systemic vascular resistance. This is also known as total peripheral resistance. Sounds like a big term, but it's very simple. It's basically talking about the resistance that your blood encounters as it moves through the pipes, as it moves through the vessels. There's 3 ways that you can alter systemic vascular resistance. 1, you can change the diameter of a blood vessel. If you decrease the diameter of a blood vessel, it's more difficult for blood to move through, and that increases the peripheral vascular resistance. You could lengthen a blood vessel. So if you were to take a blood vessel and tell it to grow longer, you may be thinking, why would a blood vessel grow longer? If somebody were to put on weight, well, there's more body mass, blood vessels need to reach distal parts of the body, blood vessels get longer, and that actually increases systemic vascular resistance. That changes blood pressure. And then the third way is you can have your blood and you can make it more viscous, make it thicker. Now, how can you make your blood thicker? Well, something called EPO, erythropoietin. Some people can dope themselves with EPO to increase the amount of red blood cells, increasing the amount of oxygen that's transported around, but it increases the sludginess or viscosity of the blood, increasing systemic vascular resistance. The easiest one to change, what do you think? Blood vessel diameter, okay? Our sympathetic nervous system, fight or flight, changes blood vessel diameter very, very quickly. So I could probably wipe these 2 out. All right, now let's have a look. Cardiac output, so that the amount of blood pumped out per minute times the diameter of a blood vessel gives you basically your blood pressure. Now, if you break down stroke volume, the amount of blood pumped out per contraction, down into blood volume itself and contractility, what we now have are the 4 values or readings which we want to alter blood pressure. What are they again? Well, we want to alter blood volume. This is going to alter blood pressure. We want to alter contractility, alters blood pressure. Alter heart rate, alters blood pressure. Alter the diameter of a blood vessel, alters blood pressure. Remember, you increase any of these things, you're going to increase blood pressure. Now, the drugs that we use to decrease blood pressure are going to tell the diameter of a blood vessel to dilate, get larger. It's going to tell the heart rate to slow down. It's going to tell contractility to be more efficient, and it's going to tell blood volume to decrease. So this is how blood pressure works and how our most common blood pressure medications work. Hi everybody, Dr. Mike here. In this video we're going to look at the aortic branches. What is the aorta? The aorta is that large vessel that exits from the left-hand side of the heart, that left ventricle. Now, as you can see, from the left ventricle we've got the aortic trunk, and coming out of the aortic trunk there's a number of different branches. We've got one branch here, one branch here, and one branch here. Let's have a look at these branches before the aorta descends down through the diaphragm into our abdomen. These 3 branches are, this first branch here is what we term the brachiocephalic. The brachiocephalic. Now, the reason why it's called the brachiocephalic, there's 2 words here. Brachio, which means arm, and cephalic, which means head. So this blood vessel is going to go and feed the head and the arm. How does it do it? Well, from this branch, you've got one that descends down this way, and one that goes up this way that we term the common carotid. So let's label this one common carotid. In actual fact, it's going to be the right common carotid. What's this? Well, this is called the right subclavian. Now, it's called the subclavian, sub meaning below, clavian is referring to the clavicle, because what we've got here is the clavicle, and it goes behind the clavicle. Okay? Now, moving a little bit to the left, we've got a branch of the aorta here, and this is going to be the left common carotid. So we've got the right common carotid there, we've got the left common carotid here, and because they're common carotids, they're going to branch off and give smaller branches, and these smaller branches include the internal and external carotids, What's important about the internal and external? Well, it's pretty easy. First of all, is that the one in the middle, they're internal. The ones on the outside, they're the external carotids. What's important? The internal carotids, they supply 80 to 85% of the brain's blood, okay? The brain gets 80 to 85% of its blood from the internal carotids, not the external. The external gives blood to the face and neck, okay? Now, what we're moving on to here is what we call the left subclavian, which means its sister is the right subclavian over here. We're going to have the clavicle that it moves behind. And let's write it up. This is the left subclavian. Now, once it's gone underneath the clavicle and it's into our arm, our upper arm, it is called the brachial. So we're going to have the left and right brachial. I'll just write it up here. Left brachial, and this is that blood vessel that we often do a manual blood pressure reading from, okay, the brachial artery. Now, there's a couple more branches for the subclavian. I'll just very quickly say two that are clinically important. They're going to branch off, right? And when they branch off, let's branch it off over here so we don't get in the road. These two branches, I want you to think about this. Remember, this is the forearm, this is at the top of the arm here, and this is going down towards the forearm, and it branches off. You have the anatomical position with the thumbs facing most laterally, and if your thumbs can turn in a circle, that means it's turning in a radius. So the radial artery is the most lateral, and the ulna is the most medial. So that means we have the radial artery here, right radial, and this is going to be right ulna. Okay. Why is this important? Because you can take a pulse from the right radial commonly. It's quite easy to do. All right, now let's continue with the aorta. Now the aorta is going down. There's going to be a couple of branches that are going to feed the esophagus, feed various particular areas, but it doesn't matter. We're going down. We go through the diaphragm. Okay, so we're going through the diaphragm, and as we go down through the diaphragm, there is a very quick, or I should say immediate branch that comes off, which is called the celiac trunk. Now this is the, like I said, the celiac trunk. And the celiac trunk has three branches that come off, which I've done a video on, okay? These branches are going to feed the liver, the stomach, the spleen, the pancreas, the lowest part of the lowest part of the esophagus, and a very minor part of the small intestines. That's what the celiac trunk does. Now, below the celiac trunk, we've got another branch called the superior mesenteric that comes off, and the superior mesenteric artery, that's going to give blood to most of the small intestines, a little bit of the large intestines. Now, basically, nearly either side of this, you're going to have a paired artery coming out, and that's going to be the renal artery that's going to give blood flow to the kidneys. The paired renal arteries. Then below that, we're going to have the inferior mesenteric artery. And the inferior mesenteric artery is going to give blood to the rest of the large intestines, rectum up to anus. Inferior mesenteric. Then as we go even further down, we're going towards the legs now. What we get is some branching off, and now what we're getting is the common iliac arteries, left and right. Common iliac. And they're going to have various branches to them, which is going to include the femoral artery. Now, these are the major branches of the aorta, okay? We've got the left ventricle pushing up the aortic arch, which is three main branches up the top. Then it goes down into the abdomen with celiac trunk, superior mesenteric, renal arteries, inferior mesenteric, and then branching for the common iliac as we go into our pelvis and legs. So these are the most common branches of the aorta.